Hello, everyone. Welcome to the Carcinoid Cancer Foundation's Facebook Live series. My name is Rain Bennett. If you aren't familiar with me, I've been moderating these. I'm a filmmaker and video producer. I've worked with CCF for almost 10 years now, creating video content to help educate people and spread awareness about NETs, neuroendocrine tumors. So we're very, very excited about this series. It's been very helpful and impactful to all the people that we've spoken to on this. We get great feedback from it. We're really, really excited to have this option to reach so many people. And so if you are just signing on, we're going to give a little intro and give everybody time to sign on. And if you are joining us today, please let us know where you are in the world. We love to find and learn where people are signing on from, because it really shows the breadth, the reach that we have and the impact that we can have through these. And so today our guest is Dr. Aman Chauhan. And Dr. Aman Chauhan, how are you, sir? Thank you for joining us.
Thank you, Rain. Thank you, Carcinoid Cancer Foundation, for having me here. It's an absolute pleasure.
Could you give us a little intro, a little bio of how you ended up here?
Yes, absolutely. So I'm a medical oncologist by training. I'm originally from India, born and brought up in a small Himalayan hill town called Shimla. Moved to US in 2011 to do my residency training in combined internal medicine and pediatrics. And that's where I found my love for neuroendocrine tumors. And I came to Kentucky to get trained with Dr. Ed Wolin and Dr. Lowell Anthony, who are key opinion leaders in this area. And I'm lucky to be able to stay back as faculty. And these days, I practice neuroendocrine oncology, and I see both high-grade and low-grade neuroendocrine tumors at Markey Cancer Center.
And I just have to add, both of those mentors are quite high caliber. So those are good people to learn under. I've worked with both of them, and they're amazing and have done so much for the field.
Yes, I think I got lucky.
Yeah, definitely. So everybody tuning in today, we're in an interesting time. We like to dedicate each of these monthly Facebook Live videos to a different topic as it pertains to neuroendocrine tumor patients. And today we're in this world of COVID-19 or the coronavirus. And so we wanted to talk specifically about your health and safety as a neuroendocrine patient during the coronavirus. Before we start, however, I want to go over some housekeeping. Today is actually a little bit of serendipity. I think today is National Doctors Day. And so we just have to give a huge heartfelt thank you to today and every day, really, to people like Dr. Chauhan and all the great doctors around the world for the fight that they do every day for our health and safety. And now more than ever, we're grateful for them and all medical professionals who are literally putting their lives on the line. They already were doing that, but now more than ever with the crisis that we're going through for us. And I just want to take a moment to thank you, doctor, and your colleagues and everybody in the healthcare and medical industry right now, because it's a tough time and I can't imagine what they're going through, but people like me and others out there benefit from all their sacrifices. So thank you to everybody.
Thank you, Rain. I really appreciate, for most healthcare providers, what we do is our calling. And we're just glad that we are able to do what we do. And I hope that everybody's safe during these tough times.
Yeah. And so if you're signing on, please know that we can't answer two case specific questions. So try to phrase your question in a generic form. Obviously everything varies case by case. And so to give Dr. Chauhan the best chance at helping you, try to ask your question in generic terms and not just specific to your case, so that he can do that. And we're going to try to give you as much information as possible, and we'll try to get to all of your questions. But sometimes I see that we have a lot of people signing on already. And so if we can't get to your question today, I encourage you to follow up with Carcinoid Cancer Foundation, either here on their Facebook page, which you're on, or their website, www.carcinoid.org. And they will try to direct you to the answers or specialists that can give you the answers. We'd like to thank our presenting sponsor, Lexicon Pharmaceuticals, as well as our supporting sponsor, Advanced Accelerator Applications, for their support of the Facebook Live program and the overall neuroendocrine tumor community. And then finally, a disclaimer. Excuse me. The opinions expressed by the guest presenters, which is Dr. Chauhan in this case, as well as the questions asked by the audience, which is you, have not been created nor suggested by the sponsors of the program, and CCF doesn't endorse nor promote any of the views, opinions, or information provided in this presentation. Audience members should rely on the opinions and information expressed by the guest presenter, should not rely rather on the guest presenter, and should seek guidance. Here's the takeaway: should seek guidance and direction from their own medical advisors regarding any choices they make about their health or treatment. So all that's really saying, it's a little bit of legalese, is saying we're going to try to help you and point you in the right direction, but by far talk to your own healthcare providers and talk to them about your treatment, because as we already established, we're going to try to help in a general term, but we can't really help on a specific case-by-case basis, and your primary care physician and your own personal healthcare providers can do that. So that's what we encourage. So Dr. Chauhan, we have a lot of questions already. We're going to go ahead and get started. Again, today's topic is COVID-19, your health and safety as a neuroendocrine tumor patient and cancer patients. And some of this will help people in general. So my first question, Dr. Chauhan, is are cancer patients all immunocompromised, and what exactly does that mean?
Well, technically, not all neuroendocrine tumor patients would be classified as immunocompromised. There are certain patients who are on certain treatments, for example, chemotherapies. Some of our high-grade neuroendocrine cancer patients might be on IV chemo, and certain low-grade neuroendocrine tumor patients could be on capecitabine temozolomide. These are cytotoxic chemotherapies and can affect immune cells, the white blood cells. And these patients are certainly at increased risk for infections. There are certain other drugs that our net community members might be aware of, like Afinitor. Afinitor is an mTOR inhibitor. It's a pale form of targeted therapy we use to treat neuroendocrine tumor patients. And before we used it in NET patients, the low dose of this particular medication was used as an immunosuppressant and still is in our transplant world. So technically, Afinitor can also cause immunosuppression, and lymphocytopenia is one of the white blood cells which helps us fight various infections, especially virus. So I would not give a blanket statement that all NET patients are immunocompromised. Certain NET patients can be immunocompromised based on what treatment they are on. And in general, I think having history of cancer or active cancer is considered one of the comorbid illnesses, just like having diabetes or high blood pressure. It's a chronic inflammatory state, and that does, in a way, can potentially affect somebody's immune system, but not necessarily an immunocompromised state per se.
And that's a term that we've heard a lot in the news recently and advice from healthcare professionals. How can you sum up, what does immunocompromise actually mean?
So we often use this term in certain infectious states where immune systems, which is basically our white blood cells, are down. For example, HIV/AIDS. There's an infectious disorder which in particular targets our immune systems. There are certain malignancies which targets immune systems, like certain lymphomas and blood disorders where white blood cells, they are downregulated. So in general, what is, to kind of build on this concept, our immunity is our ability to fight infection or any foreign agent in our body. And how our body does that is through various ways. There are various defenses that we have. Some defenses are basically physical defenses like skin. right?
Right.
So not we are not exposed to everything unless we have a cut. If a foreign pathogen is able to enter our body, then we have different sort of immune systems, like innate immune system, to kind of combat that. And then we have immune cells, for example, white blood cells, and there's subtypes of them which are geared to fight particular infections. Certain white blood cells, like neutrophils, they are more prominent in fighting bacterial infections. Lymphocytes helps us fight viral infections and parasites, etc. So these cells constitute our immune system, and a drug, a pathological state, or an inherited disorder which uh, leads
Mm-hmm.
to compromised white blood cells or subtype of white blood cell can technically lead to an immunocompromised state. That
Okay.
means these cells are either low in number or are not functioning as well as they should be.
Okay.
So together, this would constitute a clinical syndrome which would lead to an immunocompromised state, and these patients would be at added or higher risk to
Right.
develop infections.
So you mentioned chemotherapy. Let's talk about testing, current testing and treatments going on. So if I'm a patient, what conversation should I be having right now with my specialist about upcoming tests, blood work and imaging and treatments? What should I be asking them? What should I be trying to do or not do?
Right. So, Rain, like you mentioned earlier in your disclaimer, a lot of these things are nuanced and
Mm-hmm.
would be individualized for individual patient, because there's no, uh, you know, we can't cookbook this thing, right? So it would depend on the type of cancer somebody has and what treatment they're on. And it also, at present, depends on where they are. Not every state is in the same phase of COVID infection. We in Kentucky are, I think, a couple of weeks behind what's
Mm-hmm.
happening in California and New York. And we are expected to see our peak of COVID-19 cases in May.
Mm.
So things are not as disturbed in Kentucky and Lexington, but it might change in April and May. So it also depends on your environment and what's the burden on healthcare at that particular place. But your
Sure.
question is very valid. Should everybody get tested? The answer to that is no. If you have symptoms which are very consistent with the COVID-19, which is a disease caused by SARS coronavirus 2. And these symptoms constitutes fever, cough, myalgias, muscle aches, headaches, shortness of breath. Some patients can even have GI symptoms like diarrhea. So
Mm.
if patients have these symptoms, they should certainly call their provider and discuss with them about getting tested.
Now,
But yeah,
real quick, so I just want to pause there for a minute. I didn't actually know about the GI symptoms, but with the cough, I keep hearing that it's a dry cough. Is that accurate? So if, for instance, my daughter has a little stuffy nose right now and is kind of coughing from nasal drainage, that's not the symptoms we're looking for. Is that accurate?
so unfortunately, in clinical signs and symptoms, they do help us in entirety make a diagnosis and lead towards the right test. But by itself, of one particular symptom is not very sensitive or specific to either
Okay.
rule in or rule out
Okay.
coronavirus infection or not. So just by itself, like if somebody presents with productive cough, I would not be able to say this
Mm-hmm.
patient does not have coronavirus. You have to look at the whole picture. But you're right. The most reported cough symptom has been reported to be dry cough rather than productive cough. But that by itself should not be the rule,
Got
and
it.
we have to look the whole picture.
Got it. Thank you. Thank you. So do net patients, in your opinion, have to be more concerned about certain treatments than others? For example, if I'm scheduled for PRRT in the next few weeks, how would I approach that? What should I do if I take an oral chemotherapy? Do these treatments make me more at risk for the coronavirus?
Right. So let's start off with PRRT. Um, PRRT is a radiation-based targeted treatment, and it targets somatostatin receptor positive neuroendocrine tumors.
Mm-hmm.
It can lead to some decline in white blood cells, but that's not the commonest side effect. It's the decline in platelets that we are often concerned with, usually very well tolerated. In my experience, it does not cause profound immunosuppression to a point where it would lead to a significant added risk for infections. At present, in Markey Cancer Center, as I mentioned, because our COVID-19 cases have not peaked and we are not even close to that, community spread, we are currently not delaying PRT. However, we are, and by we, me and my colleague, Dr. Lowell Anthony, we're reviewing the situation on a weekly basis, and we'd be, making that call once the community infection rates have peaked and there is significant risk for acquiring COVID-19 by, for example, patient coming to healthcare facilities. We might decide at that point to delay the treatment. In the NETTER-1 clinical trial, which led to its FDA approval, and the doses of PRT was spaced every 8 weeks. However, from our European colleagues, we know that PRRT or Lutathera can be spaced, and like one of my friends usually say, there's no real magic in spacing them by 88 weeks. So based on the situation for that particular cancer center and the ground realities, we can easily extend the duration, the frequency, or delay the treatment without causing overt harm. This is in relation to PRT. Now, certain other chemotherapeutic drugs, we have to be careful because they can certainly cause immunosuppression, like I mentioned, Afinitor and Captan.
Sure.
And the decision regarding delaying treatment or holding treatment has to be individualized. I was going over ASCO, which is American Society of Clinical Oncology. It's one of the largest medical oncology associations, and they have a guidance document on their website. Of course, the caveat is we don't have a lot of data regarding COVID-19 and what should be done with regards to chemotherapeutic treatment, but they do mention that that most patients should be able to proceed with their treatment as scheduled, especially with regards to chemotherapy. Again, these have to be individualized based on the ground reality and individual patient.
Sure. So I've noticed we've gotten a lot of, and we're going to just keep moving forward with these questions because they are coming in, and it looks like at the present moment, we have the highest number of live viewers that we've had so far. So this is clearly that might be because of you, Dr. Chauhan. Let's be honest. But also this is an important topic to people. So if you are just signing on, please let us know where you are in the world. If you're already getting some value from this program and Dr. Chauhan, give us a thumbs up or a heart emoji and let us know that we're really helping you at this moment. And put your questions in. It's specifically today we're talking about how COVID-19 or the coronavirus applies to the health and safety of NET patients. But we'll try to get to your questions if we can. But Dr. Chauhan, I'm getting quite a few questions that I'm seeing from lung NET patients. So the first question I have regarding that is, what do you recommend specifically for people who have had lobectomies or have had a lung removed?
I think, again, falling back to a general caveat that we don't really have granular data regarding COVID-19 infection risk and prior history of lung NETs, or for that matter, lobectomies or
Mhm.
previous radiation history to the lung, etc. So with that caveat, I think certain things are very intuitive in our decision making right now. I would think that somebody with limited lung capacity because of lobectomy would be at added risk of complication
Mhm.
if they got infected with COVID-19. One of the one of the ways which COVID-19 affects us is by development of this bilateral pneumonia leading to what we call ARDS. Uh, Fortunately, ARDS doesn't happen to everybody, right?
Real quick, what does that stand for?
Acute respiratory distress syndrome.
Okay.
It's where the lungs and the alveoli of the lungs
Mhm.
get filled with this proteinaceous fluid,
Mm.
and which hampers the oxygen exchange between air and the blood.
Okay.
And that's the reason why we need to support the patients admitted in ICU with the ventilator because of the ARDS. However, let me reassure the viewers here. Most patients infected with COVID-19 will recover on their own, just like any other viral infection. In fact,
Okay.
75% of patients would have just minor, mild symptoms and they'll get better on their own. So I would like to reassure most patients. Now, there are 20 to 25% patients who might end up developing mild to moderate symptoms, which might need hospitalization.
Mm.
And only 5% of patients might develop significant complications and might need ICU admission and ventilator support. So for most patients, they would get a fever, sore throat, myalgias, minor symptoms, and they would overcome this and be fine. Now, I don't foresee why a lobectomy patient would have any added risk for developing COVID-19 infection. I think their risk would be probably similar to the general population.
Okay.
So they need to practice the guidelines for general population, which is social distancing, hand washing, trying to avoid sick contact. However, if they do tend to develop a COVID-19 infection, uh, then yes, potentially they they are high risk for developing complication. And this is
Mm.
theoretical. I don't have data to support
Okay.
it.
So, what if a net patient, has another disease like diabetes, let's say? Is there anything that they should additionally do besides social distancing and staying at home?
Right. So one thing we know from the Wuhan experience, there have been a couple of really good publications in the Lancet. And one thing we have learned from their experience is there are a couple of risk factors which leads to added morbidity and mortality
Mm.
with COVID-19. And these are age. Age is definitely very significant. As we've noticed the elderly people are high risk for developing complication, high rates of ICU admissions, and higher mortality. Similarly, comorbidities, and that could be not just diabetes, but high cardiovascular
Mhm.
comorbidities, obesity, um, and other chronic medical illnesses. In fact, there was a statistics mentioned in ASCO website that suggested that cardiovascular and diabetes comorbidities are probably even higher risk than having history of cancer per se in terms of comorbidities. This is based on their limited access to data. These numbers might change down the road when we have access to more data. However, regarding your question, yes, somebody with history of cancer and diabetes, we know that would be at increased risk for developing complications if they happen to develop COVID-19. However, how to mitigate or avoid infection or complication, currently the CDC guidelines are very similar for everybody. We
Okay.
don't want anybody, be it with comorbidities or not, be infected. And the way we do that is social distancing.
Mhm.
right? We try to stay away from public places, places where we can put ourselves at risk for uh, acquiring the contagion. We avoid handshakes, we avoid any physical touch, clean horizontal surfaces and fomites like door handles. We
Mhm.
know from certain studies that metals, especially steel, can have a viable virus for up to 3 days. So you got to make
Wow.
sure the horizontal surfaces are cleaned, and hand washing. Make sure you wash your hands for at least 20 seconds. A lot of people have different ways to remind themselves. It's 15, 20 seconds at least with water and soap. I have this song,
Yeah.
staying alive, and literally staying alive. So
Wow.
people gotta really heed to these guidance by CDC and WHO, and
Mhm.
just hunker down at home and avoid contact. So besides these, specifically for our cancer patients, I would like to give some additional piece of advice. And again, they might not be very rooted in evidence. However, I think these advice are, probably are low potential to harm. One of the things I would recommend is eat healthy,
Yes.
nutritious diet, right? Um, Food is medicine, and our immune system, health of our immune system is dependent on our diet, right? So I would encourage patients to eat enough vegetables and plants and a well balanced diet, so they're not nutritionally compromised. That can certainly affect the immune system. The
Mhm.
other thing I would like to mention is stress. Now, there are some studies not done in COVID 19 context, but we know that stress is nobody's friend.
Right.
Stress can affect immune system. Stress has been known to affect wound healing, so it clearly has impact on your immune systems and your body's regeneration
So
capabilities. Yeah.
So to that point about stress, we had a question. What about if someone has carcinoid syndrome? Are they at risk of going into carcinoid crisis because of this extra stress?
Theoretically, yes. Certain functional neuroendocrine tumor patients, um, can get triggered, or their syndrome can get triggered with stress. It's a
Right.
well-known, documented
Sure.
fact. And the stress is very personal, and yes, certainly we have seen in media patients with not even history of cancer. It has taken a lot of toll on a lot of people. We hear about these sad stories in the media, how stress is building up. It's not just from the COVID-19 and situation around us, but sometime being at home without our
Hmm.
friends and without socializing, which we are so
Yeah.
used to,
It's
can add
depressing.
to stress. And then on top of that, for our cancer patients, having the cancer diagnosis, and they're already under so much stress because of the medications and the rigor of the treatments, etc. So stress can certainly be a huge factor. And my recommendation would be to everybody listening here, especially cancer patients, please try to avoid stress. It's not going to help. It's only
For
going to
sure.
hurt. And certainly, in the certain nuance with nets, like you mentioned, it can certainly theoretically cause a carcinoid carcinoma. Any stress can.
Got it. Thank you. Thank you for clearing that up. So we're getting a good amount of questions from people now who are tuning in live. So I'm going to go ahead and transition to some of those. But real quickly, I had one from Carol and one from Annie regarding lung nets, and I believe that we answered those when Dr. Chauhan addressed that a little bit earlier. Carol and Annie, if you were watching and we did not answer or give you the information you needed, just shoot us back a rephrased question. But I think we covered that, and in the interest of getting to as many of the questions as possible, we're just going to move on. But let me know if we can help further.
Rain,
Um, Yes,
May I just add one more comment? I think it was a very good question. What net
absolutely.
patient can do to mitigate their, risk, complication risk.
Absolutely.
One of the things I kind of found during my research for this interview is, importance of sleep and sleep hygiene.
Hmm.
There have been a couple of really neat studies, including randomized trial, where they had two group of people, one with who had adequate sleep, both in amount of sleep, over 8 hours, and good quality of sleep, versus those with poor quality of sleep in less than 8 hours. And there was a statistically significant difference between how they responded to a viral cough and cold, and duration of their illness. So sleep certainly has, it's been shown to have effect on immune system. So I cannot emphasize enough the importance of sleep, and try to maintain a good sleep hygiene, try to get good night's rest, and good deep sleep. And insomnia is a very common problem in the
Yeah.
United States and in other parts of the world. And there are some easy tricks people can do to fool their minds. Some of those would be avoiding caffeine, or highly caffeinated sodas and coffee in the later half of the day. Trying to do some light exercise during day. Try to stay awake during day so that they're tired by the end of day,
Yeah.
and try to avoid watching television, bedroom, and just kind of keeping bedroom dark and quiet, and for sleep. So
Definitely.
very important to maintain sleep
Yeah.
hygiene.
And I totally agree. And there's so much information and research coming out now about how important sleep really is. And I just have to say, there's this thought of like hustle hard, and
Right.
burn the candle at both ends, but it's just so destructive. So I'm glad you said that, because that's such a general health issue. I think that a lot of us are going through, myself included. And I reduced the amount of caffeine that I had recently, and it's helped a lot.
Great.
I was always able to fall asleep quickly, but the quality of sleep, which you mentioned, I struggled with. I would wake up in the middle of the night. I would wake up really early. So I definitely have to plus one to that. So let's move on to some more questions. I have Helen here that asks, Sandostatin shots are on a 4-week cycle and administered at a medical facility. Are they considered essential, or can they be postponed? And I know we kind of talked about this earlier.
Right. That's a good question. And, somatostatin analogues, both cytostatin and lanreotide, are, they form the backbone for our treatments. And lot of our patients are on these somatostatin analogues. Um, should they be delayed during this? Again, these are the decisions which have to be made individually at individual level between the physician and the patient. And I think some of the guiding principles would be, one, what is the role of somatostatin analog for that particular patient? Is it just for tumor control, or is it for syndrome control? If I have a patient with carcinoid syndrome diarrhea, I would definitely want them to continue this treatment. Otherwise, they would have the symptoms, as for which they'd either have to then use multiple short-acting shots. So certainly it depends on what are we treating them for. I would also like to mention, a couple of years back, FDA approved another treatment called Zermelo, which is a pill form of treatment for carcinoid syndrome diarrhea, not controlled adequately with somatostatin analogs. That is I think in these kind of times, a pretty good treatment option, because the pills can be taken at home. So it's something to definitely consider if we are talking precisely for carcinoid syndrome diarrhea control. If the somatostatin analog shot is for tumor control, again, in Kentucky, in Lexington, based on the current situation, we are not delaying the treatment. However, come May, when our cases are anticipated to be peaking, yes, for the asymptomatic, stable patients with very indolent disease, I might delay their treatment to mitigate their risk, because at the end of the day, these are not curative treatments. These are, and I would like to reduce the risk of acquiring an infection, which might actually end up be more detrimental in short run. So you have to make these decisions based on individual situation.
Thank you. Okay, let's see. So Sierra, I believe is her name, asks, I'm currently stable and not taking sandostatin. What is the survival rate if someone like me gets sick? And I know that's maybe a little specific, but if you can answer in general terms.
Right. So it's good to hear that your disease is stable and it looks like you're doing very good to a point where you're not even on any active treatment, which is all good news. Um, I don't think in terms of COVID-19 risk, you are at any additional risk than general population. And I'd like to reassure you that most patients, 75 to 80% of patients who get infected with this disease will self-resolve with just mild symptoms. So only if you have any worsening of symptoms, especially shortness of breath, that's when you need to seek medical care. But most patients with COVID-19 would self-resolve. You need to quarantine yourself so that you don't infect others. And just like we mentioned, make sure you eat and drink well, rest well, and your body would fight it off for most patients.
Great. That's reassuring. Our next person, Doug, asks, how quickly does your immune system recover after the 14-day cycle of CAPTEM, CAPTEM? And if you could explain that acronym for me too, please.
Right. CAPTEM is a combination chemotherapy regimen of two drugs. CAP refers to capecitabine,
okay,
and TEM refers to temozolomide. So no wonder why we shortened it CAPTEM rather than capecitabine temozolomide.
Right.
This is a cytotoxic chemotherapy, and the unique nature of this chemo regimen is it's given orally. So the first pill is taken for 14 days. The other pill is taken for 5 days, from day 5 to day 14. Now, how long does somebody's is immunosuppressed is based on a couple of variables. Number one, what dose of CAPTEM they are on. Secondly, what duration of treatment and duration of cycle of treatment. So often we do 2 weeks of treatment followed by 1 week off. Then we move on to cycle number 2. Sometimes we do 2 week on and 2 week off. And if somebody has had stable disease for a really long time, especially over a year, we sometimes reduce the frequency of cycles and we do 2 weeks on, 3 weeks off, or 4 weeks off. So it depends on what particular regimen, dose, and frequency of cycle these patients are on. Typically, the blood count can be low 7 to 14 days after the treatment. I would say definitely 1 week after the treatment, but then they should start recovering back to normal. There are certain other factors which are very unique to individual patients. For example, previous history of cytotoxic chemotherapy, or duration of time with that particular patient is on CAPTEM. Because the longer you're exposed to these agents, the bigger the toll it takes on your bone marrow, and your ability to bounce back from low blood count can be somewhat compromised. However, having said that, I treat a lot of small cell lung cancer where we do give a very hefty dose of platinum-based chemotherapy. As compared to a lot of other cytotoxic chemotherapy, CAPTEM, in my experience, is not that myelotoxic and immunosuppressive, and it does have potential to do that. So that's why we check monthly CBC count. So anytime you get restarted on the new cycle, you're supposed to get some routine blood work to make sure your blood count has recovered before you go forward. In my experience, as compared to other chemotherapy drugs, it doesn't cause a similar degree of lymphocytopenia or neutropenia. But
Okay.
again, having said that, there are a lot of variables which are individual patient related, as well as what dose and frequency of keep them there on.
Got it. Thank you. Doug, hope that helps. So we have about 20 minutes left with Dr. Chauhan. I see that we are about at 180 live viewers, which is excellent. If you're tuning in now, and you know someone that would benefit from the information that we're giving today, please share this to any caregivers or any patients that you know that may benefit from the information that we're giving. I'd love to see the live viewers to get over 200. That would be awesome to see. But if those people are unable to tune in right now with the remaining 20 minutes, or if you'd like to refer back to this, just please know that we're going to have this video live here on the Facebook page for Carcinoid Cancer Foundation. So if someone wasn't able to attend today, or if you want to watch it again, it will be available right here on the Facebook page for CCF. If you're getting value still out of this, we love to see those reactions. Send us thumbs up and heart emojis and let us know that we're doing a good job, because we are here to serve you. And if you're just tuning in and you haven't told us yet, we love to find out where people are in the world. So please let us know where you're signing on from, and let Dr. Chauhan know that you appreciate him so much, and he's such a wealth of knowledge and doing such a great job.
Thank you, Rain. Thank
Yeah,
you.
of course, man. All right, so let's move forward. We have a question from Anit, and this is a great question, I think, very relevant for a lot of people. What is the proper way to quarantine in general, and specifically for NETs, for NET patients rather, if there's a difference?
Right. Um, Based on the current lack of data, I don't think we have clear-cut guidelines for NET patients. I would basically have similar guiding principles for any cancer patient,
Mhm.
and for that matter, anybody with a lot of comorbidities and medical issues. What's the appropriate way to quarantine? If somebody knows that they have fever or have been tested positive for COVID-19, I think they should limit their contact with the, definitely public. They should be wearing, if at all they have to go out of home for example, for a healthcare checkup visit, they should be wearing a mask if they are sick, because that way they can prevent the droplet from infecting other people. They have to be careful at coughing and sneezing. Try not to use your hand. If at all, you have to use the tissue and try to discard that appropriately. Um, and as I mentioned before, rest, eat well, hydrate yourself well. And if these symptoms are getting worse, and by that I mean, the fever is not subsiding and patients are developing shortness of breath, those would be some of the worrisome red flags which would recommend seeking medical advice. But most patients would overcome this, and your body would fight off, uh, you know, and can take anywhere between 1 to 2 weeks, up to 3 weeks,
Hmm.
to get better. But stay at home, try not to infect others, get some rest, and use mask when outside. Those would be some of the key key things. Right now we do not have any approved, scientifically proven cures for this disease.
Right.
There are a lot of trials looking at agents for both prophylaxis, that means to prevent COVID-19 in close family members or healthcare providers who are at high risk, and also as a treatment in those who are already tested positive for COVID-19. But at present, the jury is still out. Different countries have different guidance documents regarding the use of, chloroquine or hydroxychloroquine, azithromycin. I would recommend the viewers to follow what's been recommended in their particular region of the country. In the
Mhm.
US, as far as I know, there's no blanket approval for prophylactic use of these agents. They are under investigations, multiple trials currently ongoing, and I'm very hopeful in the next few months. Hopefully, we'll have some data. There are also trials ongoing regarding certain antiviral agents. In fact, multiple phase 3 and randomized trials going on, and I'm hopeful that one of these drugs would pan out to be helpful in
Yeah.
treating COVID-19. But as of now, we don't have a short treatment or cure which has been scientifically proven in a rigorous study.
Thank you. And thank you, Anit, for your question. So next, we've talked about lung nets a little bit so far, but Sherry asks, what is the risk for people with dip neck more or less than people with lung nets? And let's establish what dip neck is for our viewers out there.
Right. So dipnic is quite a mouthful. Rain, I'll make you repeat this. Okay. You ready for the challenge?
Yeah, I'm ready.
So DIPNISH means diffuse idiopathic pulmonary neuroendocrine cell hyperplasia. It is a type of neuroendocrine tumor. Some people consider it as a pre-neoplastic condition, which can lead to bronchial nets. And it is a type of lung net, I would say. And these patients often have asthma-like symptoms, so wheezing, shortness of breath, and chronic cough. Cough is definitely one of troublesome, symptoms with these patients. Again, just as I mentioned, this is a very rare subset of neuroendocrine tumors. So certainly we do not have data regarding DIPNISH and added risk of COVID-19 complication. However, I would, theoretically, anybody with compromised lung, they are certainly at high risk for developing complications from COVID-19. Not necessarily that they are at high risk for developing COVID-19. Their risk for acquiring infection is similar to general population. However, if they do tend to develop COVID-19, then could they develop complications at a higher rate than a normal healthy person? Certainly possible. We don't have data for that. Also, DIPNISH, there are various, depends on how, what's the burden of DIPNISH and what has been done for that particular patient, as that patient underwent lobectomy and has compromised lung at baseline. So these are a lot of factors which would dictate the overall outcome and the risk stratification.
Great, thank you. Ed asks, is there an additional systemic burden for someone who has carcinoid syndrome with elevated serotonin levels as well as a midgut net? Is there an additional systemic burden?
Carcinoid syndrome, especially if it's an uncontrolled carcinoid syndrome, we know that these patients in general do worse as compared to somebody who don't have carcinoid syndrome or have well-controlled carcinoid syndrome, right? So that's a historical data. So that's why one of the key goals in the management of neuroendocrine tumors is to control the carcinoid syndrome, control the urinary 5-HIA to a point where patients don't develop these complications down the road. And, but vis-a-vis COVID-19 in the short term, I do not foresee that an acute infectious condition like COVID-19 would confer any added risk to somebody with carcinoid syndrome, controlled or uncontrolled. I think, like it's a common theme. We've discussed this multiple times earlier today. Anybody with chronic medical issues, health issues, they are they are at added disadvantage when dealing with COVID-19, age, etc. So those are the factors which have been well established for the time being. I don't think a carcinoid syndrome patient would be overtly at a higher risk than non-syndrome patient vis-a-vis COVID-19.
Got it. Thank you. So we seem to have a lot of people kind of interested in their risk level and if they're at higher risk depending on their existing condition or disease or what net they may have. In general, and let me know if I'm correct here. It seems like you're saying almost any other pre-existing condition puts them a little bit at higher risk, but they still should abide by like just being as safe as possible. Is that accurate?
That is correct. And again, our experience regarding this condition, COVID-19, and morbidity and mortality so far comes from the Wuhan and Chinese experience, and now from European experience.
Mm-hmm.
And what we have noticed is the factors which really affect the outcomes are certainly age and comorbidities like previous underlying health issues, diabetes, cardiovascular problems. Those are certainly very important to be noted. Uh, History of cancer, certainly, there was a recent publication in the Lancet Oncology from China. However, it's a very small cohort. I think 18 patients, cancer patients with COVID-19. So uh, the authors concluded that cancer definitely is a risk factor for a poor outcome. However, we need to confirm these small anecdotal findings. These
Yeah.
are not strong data. At present, I would advise caution to almost everybody with any sort of medical condition, especially cancer, diabetes, heart disease, chronic lung diseases like COPD,
Yeah.
etc. I think, and elderly, 60 and over. From our experience and from the literature right now, they are at added risk for developing complication. But COVID-19 is a great equalizer. We have seen patients, young and old,
Right.
healthy and debilitated, rich and poor. Everybody gets affected by this disease. The good news is most patients would recover.
Mm-hmm.
Okay, so that's one important thing I want to reassure our audience here, that most patients will recover, and they would only incur some minor symptoms. So it's really important for patients not develop panic, not be anxious, and do not stress is not helpful in this situation.
Right. Right. Thank you. Yeah, because I'm starting to see a lot of questions that are similar, and to everyone listening or watching out there, if you signed on a little later, there's a good chance we may have addressed the question that you have or the issue that you're concerned with. So please, I encourage you to, after the Facebook Live is done, which we've got Dr. Chauhan for about 10 more minutes, go back and watch this. If you can, we also repost them on Carcinoid Cancer Foundation's YouTube channel, and we have those in more specific subtopics. But yes, go back and watch the video, because a lot of our questions are similar, which it's understandable because everybody's worried and everybody's stressed. But Dr. Chauhan has done a great job of letting us know the way we should approach this and what we really have to be concerned with most as NET patients. So, okay, we have a specific question about some treatment. We have Adrian who asks, I am trying to self-isolate at home, which is great, and I'm currently receiving octreotide, 30 milligrams. Do you see any issues with this?
Um, I don't think there's any issues with continuing octreotide. Octreotide, to my knowledge, is not an immunosuppressant. I think the only worry certain colleagues at certain places would be based on the ground situation. Is there any added risk for the
Mm-hmm.
patient coming to a healthcare facility of him acquiring COVID-19?
Mm-hmm.
And those things have to be dealt at local level. Again, every state in the United States are in a very different phase of community infection rates. For example, Lexington, Kentucky, we are supposed to have peak rates in May. So things are basically functioning normally, at least for the cancer patient in our center right now. These things might change as situations very fluid. So it depends. As somebody is in New York, things are completely different. And I think if a routine care, again, we mentioned earlier, if somebody is on sandostatin or lanreotide for just disease control, is rather asymptomatic patient, has a well-controlled disease for several months, in fact, years, I think looking at situation, they can potentially, uh, delay or reschedule their
Hmm.
shot. But per se, sandostatin by itself does not cause immunosuppression, so it's a safe drug to go. I wish, maybe this could be an opportunity for our industry partners who make sandostatin and lanreotide to push for a legislation where we can provide these shots to our patients at home, like in Europe. So in Europe, patients can get these monthly shots at home with the help of home health. But here, the way our I think reimbursement structure or billing structure is, I think it's not allowed to be given at home. Again, this is something
Hmm.
I think we should use this as an opportunity to kind of work towards this.
Okay. Thank you. We have about 5 more minutes, so I've got about three more questions I'm going to ask Dr. Chauhan. Aneet, who we heard from earlier with a great question, asks, SARS and MERS were not that lethal here in India. Should we expect a similar response for COVID-19?
Right. So that's a very good question, actually. SARS, MERS were both coronavirus caused illnesses. Of course, different type of coronaviruses. SARS was seen in 2002 in China and had a high case fatality rate of 8%. MERS had case fatality rate, I think, 30%, or something in that range, so very high. However, both these illnesses did not spread anywhere close to the same extent as we are seeing with COVID-19. And we are trying to understand those reasons why. Perhaps there is some new data coming up that the COVID-19 virus replicates really fast and much earlier as compared to SARS. And so patients might be shedding a lot of virus,
Mhm.
before they even get symptomatic. And that's how patients are getting exposed before they're, it's overtly known that somebody is sick. However, COVID-19 has to be taken, we should not compare it with SARS and MERS. The current trend has shown that in matter of months, COVID-19 has engulfed almost the entire planet. There are hardly any countries left untouched by infection,
Right.
right? And so it is a very contagious illness. The case fatality rates are much, much low as compared to MERS and SARS,
Mhm.
which is a good news. Um, but the infection rates are very high. It's very contagious.
Yeah.
So again, really important, and there's a need for social distancing so that we can flatten that curves and not everybody gets sick at the same time, and then end up needing hospital resources.
Mm.
Yes, but the case fatality rate is very low. Now, I'd like to point out one thing here. I don't want to comment on the actual numbers. Just like SARS, we know the case fatality rates like a 10%, and MERS 32%. For COVID-19, we don't have a clear-cut case fatality rate. And basically, case fatality rate means how many patients died and how many got infected. So it's a measure of that. And as you can understand, it depends on how many cases are being screened for COVID-19 infection. So
Sure.
in populations where everybody's getting screened, like South Korea, the case fatality rate is 0.5.
Hmm.
If limited patients are getting screened because of either logistical issues, there's not enough test kits available, or some other causes, the case fatality rate could be high. For example, in Italy, 7 to 9%. In US, we don't have a reliable data yet. So
Right.
I would not go by an actual number. I think people need to understand this is much less fatal as compared to the other illnesses. However, it's a lot more contagious. It can
Right.
spread much faster. So people need to take it seriously and practice social distancing and hand hygiene, as been advocated by CDC and WHO.
Thank you. And to that point, we have an interesting question from Jennifer, who says, "I work at a hospital in a lab, and I'm still working. I am also taking lanreotide and was diagnosed with NETs in February. Is this okay?"
That is completely okay.
Okay.
Lanreotide is a somatostatin analog and is does not cause immunosuppression. Um, if your healthcare provider are providing these cares and are not considering delaying based on the situation in your area, it's completely safe. It does not put you at added risk for complications from COVID-19. Again, I think there are factors besides just the drug and the host, which will dictate whether there should be we should consider delaying treatment. That would be based on the healthcare scenario of that particular area. You don't want to be going to the hospital if
Mm-hmm.
there are tons and tons of COVID-19 cases in that particular
So,
area.
so if you delayed your lanreotide injections, that would be okay as well.
Absolutely. If
Okay.
somebody is on lanreotide just for tumor control, for rather indolent disease, I think it's very safe to
Okay.
delay it as well. I would not get too anxious if it gets delayed. One of the neat things about especially low-grade neuroendocrine tumor is that it's an indolent disease. It doesn't grow very fast. Again,
Mm-hmm.
these are I hate to make these blanket statements because a lot also depends on the individual grade of the tumor. But for most patients with low-grade disease, it's a very slow-growing cancer, unlike some of our other cancers like breast cancers or small cell lung cancer or leukemias. So it's a very different disease, and I feel very comfortable holding the
Good.
treatment if that's the need of the hour for that particular place in the community.
Good. Okay, final question. I think this is relevant. This is from Alan, because many people, uh, we're all people who are dealing with NETs are particularly stressed about this because they already have a disease which may make them higher risk. But a lot of us know or live with people who are healthcare providers and spending a lot of time at hospitals, and that's another concern. So Alan asks, "I'm recently recovering from surgery and on lanreotide as well, and my wife works in a hospital. What should I do to protect myself? Are there any other particular measures that he should take?"
Right. So that's a real concern. And
Mm,
because of that concern, a lot of societies, especially surgical society of oncology and other healthcare societies are grappling with this question regarding surgeries because surgeries come with a period of convalescence, and these patients can be in the hospital, and being in hospitals added risk for nosocomial infections, etc. So, since the viewer you're alluding to it already had the surgery, a lot of places people are delaying elective surgeries if
sure.
possible. That's our current guidelines, and same here in Lexington. If it's an elective surgery, we are trying to delay it. However, somebody's already had surgery. Of course, I would defer to the local team of the surgeons, but as soon as the patient can be discharged home and safe for him to be home, I think home is a good environment to be in. And if this is a very unique situation because the patient's family member, very close family member, is also a healthcare provider, and
Right.
I would, what I'm doing personally,
Yeah.
except for your event today, I wore a dye and a jacket. I'm usually moved to scrubs, and my game plan is to use scrubs. And as soon as I reach home, I dump them into the washer, change to a clean piece of clothes, keep my hands clean, wash my hands often, and maintain, in this particular scenario, probably safe to maintain about 6 feet of distance if somebody is high risk and
Hmm.
their spouse is working frontline in the ER or ICU. You would see on Twitter a lot of healthcare providers are trying to maintain that distance with the close family because they're scared that
Yeah.
they would infect
Imagine.
their family members. this is an evolving situation. Unfortunately, I don't have a good answer for this, and we just need to use our judgment and try to mitigate that risk. Social distancing, hand hygiene, cleanliness, and avoid sick people. If your wife does get symptoms, I would probably use mask. She should use mask, and of course,
Okay.
try to distance as much as possible.
Sure. Well, thank you, Dr. Chauhan. We are a little bit over, but that's okay because that means that we just provided a little extra value for the viewers out there. And if you all did receive that value, we love to get those thumbs up and those heart emojis to let us know. Dr. Chauhan, thank you so much for your time. I appreciate you taking off the scrubs and getting all dressed up for us, and just taking time out of your day. I know that your schedule is probably crazy right now, and life is crazy for all of us, but I think this is super helpful. Any parting words? I know you've been great at reducing some of the fear and helping people understand what this is and what it isn't. Any final words for NET patients and how they can proceed, in the near future, which we're not sure when we're going to get out of this pandemic?
First of all, I'd like to thank you and Grace and the team of Carcinoid Cancer Foundation for organizing this. As you can see, a lot of people are anxious in this time, especially our NET patients. But I'm glad that you gave me an opportunity to talk to them directly and kind of allay their fears and anxieties. As I mentioned again, again and again, that most patients would develop only mild symptoms and would overcome this. Their bodies will deal and take care of it. So the worst thing anybody can do to themselves right now is build on stress. Stress not good. So I want to final words would be hand washing, social distancing, eat healthy, avoid stress, and have good sleep. Everybody's in lockdown. This is the best time to sleep, right? So nobody should have any complaints regarding that. Thank you so much. And I wish everybody, good health and be safe.
Absolutely. Absolutely. I second that. And everybody listening, thank you so much as well for joining us again. We hope that we helped you, and we hope that we got to your questions. And again, if we didn't, I encourage you to, one, go back and watch this video. It'll live right here on the Facebook page, or send a message to the Carcinoid Cancer Foundation here, either on the Facebook page or at their website carcinoid.org. Again, we want to thank our presenting sponsor, Lexington Pharmaceuticals, as well as our supporting sponsor, Advanced Accelerator Applications. Without their help and support, this whole program wouldn't be possible. And we hope you join us next month as we continue the Carcinoid Cancer Foundation Facebook Live series. Thanks, everybody, for attending today. We had some great numbers, and I hope you all and your loved ones are healthy and safe out there. Be well.